Lisa would like to take it away.
All right, good morning. My name is Lisa Violal. I'm the Medical Director for the Division of Public Health Preparedness at the Arizona Department of Health Services. And I'm also the Medical Director for the Health Emergency Operations Center for the COVID-19 response at ADHS. Presenting here with me are Charles Larson. He is the Initial Project Manager for the Arizona Surge Line at the Arizona Department of Health Services, and Terry Mullins, Chief of EMS and Trauma Systems here at ADHS. It is our pleasure to have a chance to present this new Arizona resource. We ask that you submit your questions through the chat box, and then at the end we'll get to as many as we can. All right, let's see if we can get this PowerPoint up on the screen.
All right.
Perfect, and next slide. This is what we plan on covering today, basically the background and reason why the Arizona Surge Line was created, and then into more of what it actually does and how it does it. Next slide. And to start with the background, next slide.
Yep.
As you're aware, Arizona has been preparing for a surge in hospital admissions due to COVID-19. And we've seen hospital systems and facilities collaborating in a truly unprecedented way to address and prepare for this anticipated surge. And the Surge Line is a product of that collaboration. Next slide.
Sorry.
No, that's good. Next slide again.
Okay.
Nope, sorry, back to. Yes, okay. So, yes, there we go, the pandemic triage level. So, this is just a background slide. We know that things change throughout a pandemic, and this is kind of what we're preparing for. Right now, we are in triage level 1, or conventional or normal care, and then we're preparing for triage level 2, or contingency, and that's when you see hospitals at maximum bed capacity and resources are becoming a little scarcer, and hospital staff absenteeism is around 20-ish%. And then as you move into triage level 3, or crisis level, that's when you see hospitals out of resources, absenteeism is high, we're starting to run out of transport, and we are entering into altered standards of care. So right now we're at level 1, conventional, we are preparing for contingency and crisis. I will say that it's unclear when elevation to this next level, level 2, level 3, when that will need to occur. As I'm sure you know, that elevation will be impacted by social mitigation and other public health strategies. A secondary surge is highly likely, and we do anticipate seeing more strain on our hospital systems when we see COVID coinciding with flu season. Next slide. Okay, moving on to the structure. Next slide. So in light of this anticipated hospital surge, the idea was to create a 24/7 toll-free call line, like a one-stop call line, that could help expedite transfers of patients from one facility to another, whether it's moving to higher levels of care, to lower levels of care, and just doing that through a centralized platform to speed the process and equalize the hospital burden across the state so that no one hospital is reaching level 2 or contingency or crisis levels, for example, before another. Next slide. This is just another way of saying that. This is our mission, and we would wish to do those same 3 bullets there at the bottom with efficiency, consistency, and ethical consideration. Next slide. In terms of scope, this resource is meant to be statewide. It is meant to be a service available to private, public, and federal healthcare facilities. It is intended to be used only for the transfer of presumed or confirmed COVID-19 patients, and it's anticipated to be active for the duration of the COVID-19 emergency, so not forever. Next slide. This call service would be maintained by the Arizona Department of Health Services and would be free, and it is free for healthcare facilities to use. Its process flows that it functions under were based on protocols that were jointly developed by an Arizona work group made up of different hospital transfer centers and chief medical officers. Next slide. So this is the core of this surge line. There are 4 key components. The first is to expedite patient transfer to a higher level of care when indicated. The second is to expedite patient transfer to a lower level of care when indicated. The third is to provide a safety net for interfacility transport when resources are scarce. And the fourth is to provide critical care and palliative care consultation. Let's go into each of these into more detail. Next slide. Okay, so for the first component, when we say that the surge line will expedite patient transfer to a higher level of care, we mean to say we would like to expedite transfer to a facility with a higher relative capacity. So we're thinking, for example, med-surg beds, ICU beds, or ventilators. Next slide. When we say the surge line will expedite patient transfers to a lower level of care when clinically indicated, that's basically saying that we want to assist with patient disposition, whether that's to an alternate care site, to a homeless shelter, to a step-down unit, and so on. You know, we all know patients often stay in the hospital due to these disposition and coordination challenges, and we'd really like to use the surge line to help open up those hospital beds in times of surge. Next slide. The third component is to act as a safety net for the interfacility transport of presumed or confirmed COVID-19 patients when there are challenges with transport. With the numbers that we're currently seeing, and we're aware of the large surge capacity of our current patient transport system, we don't anticipate needing this very frequently, but we are preparing it just the same. With the activation of the surge line, which it is now activated, all hospitals and transport systems should continue to arrange and manage transport as per normal protocols. The surge line would just act as a safety net to help arrange that transport or to request federal transport resources when we start to run into challenges. We do find this to be an important part of the surge line because if we get into a situation where there are beds and ventilators available but no transport to that bed or to that ventilator, then we won't be able to optimize patient placement and care. Next slide. This fourth component is a nice one, and it's one that we haven't seen factored into other states and their call lines, which is that if a patient cannot be transferred and or transported because of a lack of beds, a lack of resources, or a lack of transport, or if the time to expected transport is over 60 minutes, the sending physician will be offered a real-time critical care or palliative care consultation with an Arizona physician to help them manage their patient in place. Next slide. In terms of how we're going to be able to do all this, the data that we're going to be using to make decisions about patient transfer will be based on real-time bed and ventilator surveillance. The concept is to maintain this surveillance statewide so we can see where the availability is, which hospitals are filling faster than others, and then we can help place a patient accordingly. We will start out using EM resource, and then we will, for our bed and ventilator availability surveillance, and then we will transition into a more automatic bed board update through Central Logic and the HIE. Next slide. So the overall process flow is the following. So the originating facility calls the surge line. The surge line performs a minimum clinical intake. The surge line agent looks at the state bed board and determines the appropriate destination healthcare system in Arizona, then patches that first caller through to the destination transfer center that's been selected. And then the destination transfer center takes over, does the intake, gets their physician approval, bed placement, and arranges transport as they always and usually do. Next slide. This process changes slightly when we run into greater surge and when triage protocols are being implemented in facilities. So that means we're getting into that level 2 or 3, contingency or crisis levels. If a destination facility declines the transfer of a patient due to their triage protocols, there will be an appeals process. And if a patient is unable to be transferred or transported, the requesting provider, as we mentioned earlier, will be offered that real-time critical care or palliative care consult. Next slide. The surge line staff is going to be made up of EMCPs and dispatchers here in Arizona. The consulting physicians also come from Arizona and are either critical care or palliative care specialists. Next. In terms of how these algorithms were determined to choose the appropriate destination facility for patient placement, there are several criteria that are used for determining that, including the comparative available beds that we see on the bed board, where the last 10 patients had been placed, and at least for level 1, conventional or normal, or where we are right now, we are going to take into consideration whichever is closest to the sending location. Next slide. Hospital participation with the surge line has been rather inspiring, actually. I think only one hospital so far has declined to participate, but all others, including most federal facilities, have been 100% participatory. If there is a hospital that happens to be on the line on this webinar and is not aware of the surge line, please email us at surgeline@azdhs.gov, and we can send you guys a startup packet with the data requirements and collaboration principles. We will be asking a few things of participants, hopefully all of which have a $0 direct cost to it. First is that all requests that your facility places for a COVID-19 transfer should go through this surge line. Number 2, all requests your facility receives for a COVID transfer should be redirected to the Arizona surge line if it didn't come through the surge line originally. Number 3, we ask that your facility maintains bed surveillance either manually or automatically through the offered systems. And number 4, that facilities agree to have an internal protocol so that they have a 30-minute turnaround time from to bed placement from the time that the Arizona surge line first contacts them. Next slide. These are just the materials that are included in the hospital startup packet. This packet will not be posted online, but it will be emailed out to all hospitals. Next slide. As for the EMS CEO community that's on this webinar, I know that there are a lot of questions about the surge line, and there's just a couple of things that I wanted to make sure to clarify. The first is that the surge line honors existing transportation agreements. Second, the surge line is not going to interfere with 911 calls or pre-hospital transportation. This is only for interfacility transfers, not from transfers from home, for example, to the ED. And number 3, I don't think that you all should feel too much change from this other than possibly an increase in the interfacility transportation because we are potentially moving people around a little bit more than usual to higher levels of care, lower levels of care, etc. Next slide. I would like to say that this is a new system. This is a new endeavor. We have never tried this at this scale here in Arizona. So just a couple clarifications in case it wasn't, just a couple clarifications. The first is that the surge line works with the transfer centers and the EMS and patient transport companies. It doesn't change those arrangements, contracts, or protocols. Second, the surge line works and interacts with public, private, and nearly all federal healthcare facilities. It does not work and interact with the public. And number 3, the surge line number should not and will not be posted publicly in an attempt to protect the call line, but all hospitals and transfer centers, hospital alliances, and associations will have this number. Next slide. And okay, in terms of evaluating this next service, next slide. Evaluations will be administered to the surge line staff, to the physician consultants that will be participating, and to the hospital transfer centers. Analytics will also be created looking at the surge line, including the number of transfers from what hospitals, with what transport agencies, and the turnaround time on a regular basis. And again, this is a new service here, but if it works, it could potentially be used and stood up for the next event. Be it nuclear, the next pandemic, fire, mass casualty, anything, that would possibly create a hospital surge. Next slide. As for next steps, next slide. The rollout of these 4 components, as for the rollout, expediting patient transfer to a higher level of care is already done, and it's up, and it's working. It's already being utilized across the state. As for the remaining components, the safety net for transportation, the consultation line, those should be able to be up within the next few weeks, and then trailing another week or so behind them is number 2, which is expediting patient transfer to a lower level of care. Next slide. That is actually all the presentation that we have here today. There is more information on the SurgeLine website, and this, I believe, webinar will be posted there. in another few days. If at the website listed here, if you have any questions, please email searchline@azdhs.gov. Thank you so much for your attention, and I think we have some time for questions if they've come through on the chat line.